So my talk is intraparto management of intrauterine growth restriction, which I think in Spanish you call RCIU. And just to tell you a small story, I read RCIU and I misinterpreted it as repeat cesarean section. So I prepared also a talk on management of patients for VBAC with prior C-sections in labor. So in case you want to hear it sometime, let me know. But it's ready. I spent some good time doing that. Intrauterine growth restriction is a baby that is smaller than normal during pregnancy. Babies that have IUG, intrauterine growth restriction, are more likely to have certain health problems: difficult time handling stress of vaginal delivery, increased risk of being stillborn, low blood sugar, low resistance to infection, trouble maintaining body temperature. So they have a lot of complications that we as obstetricians need to be aware of. So here you can see normal sized baby, smaller one, and the same one growing up retains being smaller. Diagnosis of IUGR, we're not talking about mainly about diagnosis, but I thought it's a nice thing just to show you a couple of slides of it. The sensitive specificity of IUGR is best with an estimated fetal weight 89 and 88%. Decreased amniotic fluid is not a good sensitive way to diagnose IUGR. So it's still estimated fetal weight by ultrasound, and most people do head circumference, BPD, abdominal circumference, and femur length, and also elevated HC to AC ratio. But those are specifically for asymmetrical IUGR, not for symmetrical IUGR. Everybody has their own growth curves. When fetuses fall off the growth curves, they consider IUGR. Do you have one for Bogota? Do you have a specific growth curve for Bogota? I'll gladly work with you on making one. It would be a great publication. Do you know why? Because you're 25 meters high. Am I correct? 25? 20, something like that? 2,600? And babies are smaller. So in the United States, we have one city that is relatively high. It's called the Mile High City. It's not as high as Bogota. It's Denver, Colorado. And they have their own growth curve. So babies born at higher altitudes, on average, have low birth weights. If you use a normal birth weight graph like this one, or like this one, for babies at sea level, you will overdiagnose IUGR. And that's not something you want a percentile. It's relatively easy to do. And singletons are bigger than twins, so you need to use a different growth curve sometimes for twins. And you need to know the factors of intrauterine growth restriction: maternal, placental, fetal, and demographic. Demographic is the population. We have in the United States an increasing number of Indian, not indigent Indian, but from the country of India, doctors. And when we do their ultrasound, they have a large number of babies that are smaller, below the growth curves. We cannot use our normal growth curves for them, because then we would overdiagnose IUGR. So for different people, for different localities, you might need a different growth curves: maternal, placental, and fetal reasons. And these are the normal one: normal head, normal abdomen; symmetrical IUGR, small head, small abdomen; asymmetrical IUGR. And it's really important for you to realize what you got before you go into labor and delivery. There are very few, if any, papers out there of management of IUGR in labor and delivery. And most of it is sort of hand-me-down from other people. Symmetrical IUGR, usually before 32 weeks, 25% risk of fetal anomalies. Asymmetrical IUGR, early in the third trimester, impaired growth of the body, but normal growth of the head. And the symmetrical IUGR is the fetal one, and the asymmetrical one is usually maternal or placental one. And these are all fetal factors. We won't go through them because it's not really what we're talking about. Chromosomal, congenital, and then there are maternal factors, medical conditions. And I think in your circumstance, it probably would be asymmetrical IGR as a cause of preeclampsia and hypertension be a major cause. We do amniotic fluid on those babies once we make the diagnosis. When do you do routine ultrasounds in Colombia? Routine ultrasounds are done when? In Germany, where I come from, routine ultrasounds are done 4 times. By law. The first one at the diagnosis to look at twins and to look at ectopics. The second one, 11 to 12 weeks, to look at nuchal screen. The third one at 20 weeks to look at malformations. And routinely, all patients get one at 32 weeks, around 32 weeks, to look for IGR. Because the clinical diagnosis of IGR and the ultrasound diagnosis of IGR is totally different. We miss about 50% of IGRs when we just look at it from a clinical point, when we just measure the uterine size. So do you do it 32 weeks routinely here? You don't do it. You don't do it here. So my recommendation is try to do it. I usually do it in my office. Quick, it takes me 5 minutes, less than 5 minutes, to do the 4 measurements. You push a button and it comes out. So once you make the diagnosis of IGR, and again, you need to understand how you make that diagnosis. This is one scheme of following up babies with IGR. You do umbilical artery Doppler. If it's normal, you follow up on it, and you can deliver term. If there's a normal Doppler and oligohydramnios, not enough fluid, we should do a daily full biophysical profile and when we deliver. If the umbilical artery Doppler shows reverse end diastolic flow, we deliver. Absent end diastolic flow, we observe very closely and also usually deliver. And when there's oligohydramnios. So with oligohydramnios, you always deliver early. With normal Doppler, you can continue and watch. With biophysicals and with abnormal Doppler, you need to watch them really closely. So once you decide to deliver this baby, you need to understand how your department works. How is the RCIU? How are the pediatricians? Avoid hypothermia, surfactant, prevent heat loss, because those babies with IGR are much more sensitive to any kind of complications. For the diagnosis, you need an accurate gestational age. Many patients are misdiagnosed because we do not know how many weeks pregnant they are. And you need to have a weight percentile that's calculated from the estimated fetal weight and gestational age. 2 standard deviations or the 10th percentile, you need to decide at your own institution what your cutoff is. And also sometimes what we do is when we see a baby that's around the 10th, 15th percentile, we repeat it 2 to 3 weeks later, and then we do a growth curve and see if it falls off or not. And that's probably a significant thing you need to know about. Babies with IGR have an increased risk of cerebral palsy. And this is a paper published last year at the Journal of Epidemiology, where they looked at cerebral palsy and restricted growth status at birth. And they wanted to make sure that they understand why babies are more likely to have cerebral palsy. They had 334 cases, 1/3 were preterm, 2/3 were term. Children with cerebral palsy who were delivered preterm did not have an increased risk of IGR. In contrast, children with CP who were born at term were more likely to have severe IGR. And their conclusion is children with severe IGR at term have an 8-fold risk of CP. So it's the term ones with IGR that you need to be specifically concerned about in terms of cerebral palsy. Term singletons with severe, small for gestational age birthways have a 5 to 7-fold risk of developing cerebral palsy. And this is important for you to explain to the parents. Sometimes it's painful, but they need to know that if you make a diagnosis of term IGR, there's an increased risk of cerebral palsy. Now, the risk of cerebral palsy in the general population is 1 to 2 per 1,000. The 5 times risk is 5 in 1,000. So still, the overall risk is low, but it's clearly increased. Antenatal risk factors for CP, it's the term ones that have an increased risk of all CP, and so that's another paper that proves the same thing. And this was published last year in the Journal of Perinatal Medicine. I was one of the co-authors. And what we said is when the cause is of placental origin, it's possible to identify the affected fetuses, and the major complication is chronic fetal hypoxia. So the asymmetrical ones are the ones you need to be concerned about specifically on labor and delivery. And the questions when you should induce labor is a little bit controversial. This is a paper published in the Systemic Review, British Journal of OBGYN, just a couple of months ago. And they said for IUGR preterm or term, for preterm 1, there's a good evidence, but a weak grade of recommendation. So it's not clear from all the papers reviewed when and how you should deliver those babies early on. When should you induce IUGR babies? Expected management results in a 4-day average prolongation of pregnancy. There were more stillbirth and delayed, so if you wait longer, there's an increased risk of intervention. There was no difference in perinatal mortality, and a 2-year follow-up studies of infant development were conducted of 98% of surviving participants, and there was no overall difference if you wait or induce right away. So the jury, as we say, is still out whether you should deliver right away or not, and how you should do the surveillance. They also said this is a Cochrane review. More studies are needed to evaluate the effects of currently used fetal surveillance, whether it's AFI, biophysical profile, non-stress test, or Dopplers. Doppler, I think most of you do on a routine basis. These are the Dopplers: a positive anti-diastolic flow, good; absent anti-diastolic flow, bad; reverse flow, even worse. So sometimes you can see that happening. And once we see reverse anti-diastolic flow, we deliver the patient. The problem is if you have a patient under 32 or under 30 weeks, what are you going to do? Because the risk of prematurity at that point is extremely high. But once they reach 32 weeks, I think most of us will deliver with an absent anti-diastolic flow. Normal, reverse anti-diastolic flow. So which patients are candidates for induction of labor? Some of us, and I like to do an oxytocin challenge test. If it's negative, and if the biophysical profile is okay, and the visual heartbeat and positive Doppler flow, they are a candidate for inducing labor, but no good candidates when they're late decelerations already, when the biophysical profile is not okay, and absent anti-diastolic flow. So you need to choose patients carefully before you start inducing labor. Caesarean delivery is preferred when you have evidence of positive OCT, when there's another abnormal tracing, abnormal biophysical, reverse anti-diastolic flow, and then for traditional obstetrics. And most people are going to be very, very liberal. They're going to do C-sections more frequently, depending on what they find. Delivery of IUGR babies should take place in centers where appropriate neonatal assistance can be provided. Make sure you talk to the neonatologist. We talked previously about communications. It's important to tell the neonatologist before you bring the patient in that this patient is there on that day, and you need to carefully monitor the babies. The delivery mode, again, depends on fetal conditions and also on the Doppler. The more pronounced the hypoxia and acidemia, the more likely the fetus will not tolerate labor. So no matter what you do, the baby will be in bad shape, even if you do a cesarean section. You need to decide on timing of delivery, cesarean section versus induction, and more importantly, you have to look at the etiology of the IUGR baby. Symmetrical versus asymmetrical, placenta versus other causes. And this is something that I thought might be very helpful. Symmetrical IUGR babies do well in labor but they don't do okay postpartum because they usually have other malformations. Asymmetrical babies do not do okay in labor because they do have a placental factor usually, but if they deliver okay with no acidemia, then they will do fine postpartum. So IUGR fetuses from a placental or from maternal conditions are less likely to tolerate labor than those from fetal conditions. I showed you one. This also was an IUGR baby. I've seen 2 babies myself die with the first contraction, severe IUGR babies. You need to understand that those babies can have a perfect, reassuring, perfect variability, non-stress test. 1 contraction, less oxygen, they can decompensate. So you need to be very careful. You need to prep for those babies ahead of time. Assess your labor and delivery unit regularly to find out how quickly you can deliver a baby with prolonged deceleration. Do regular drills. We talked about drills. We're going to talk about them. The last talk I'm going to give tomorrow will talk about drills. And there are several drills you can do. We start off with shoulder dystocia drills, fetal bradycardia drills, and also hemorrhage drills. And you need to understand at your own unit. And this graph is something that is crucial. And I dare to say that most units have never done this before. You need to figure out at your own unit how long it takes from the time you make a decision to do a cesarean section in emergency to the time you make an incision and the baby is delivered. You need to have a stopwatch and figure it out minute by minute by minute by minute. And once you have figured it out, theoretically, you need to then, in practice, do a drill. Do it on a day, go into a room and call people and say, fetal bradycardia, you guys manage it now. And then you have a stopwatch and figure it out. Because with IUGR babies and with other babies, you want to deliver this baby in less than 10 minutes. Less than 10 minutes. Really important. Get the OR ready before you start Pitocin. Communicate with everybody. Let everybody know, anesthesia, pediatrics, that you are about to give Pitocin to a baby with intrauterine growth restriction. And one question you might have, you might decrease your time by at least 2 minutes by having the patient have adequate anesthesia. It takes time to start the anesthesia. Understand all the abnormal fetal monitoring patterns, late decelerations, early decelerations, so people understand what's going on. Smooth, no variability, and you're going to have long decelerations below 70 per minute. I would say that in asymmetrical babies, misoprostol is not the perfect way to induce labor. It's cheaper, obviously, but it cannot be titrated and the dose is unknown, and there's increased risk of tachysystole, hyperstimulation with misoprostol. That's something studies have shown again and again. So if you have a baby with asymmetrical IUGR, I think giving misoprostol is not the best choice. Understand what a positive OCT is, late decelerations with over 50% of contractions, and these are the kind of tracings you don't like to see. We often see them in patients in the second stage of labor, but you don't want to see them early on in IUGR babies. If you see them early on, you really want to deliver this baby as soon as possible. This is what I call a non-reassuring variable deceleration, and all of your team needs to look at those tracing and understand these are different than the ones you see in normal labor. No anterior posterior shoulder. They tend to slide into deceleration. See? Look at this, slowly over a minute. Somewhat sluggish matter. See, it's slow. This is not an all of a sudden one. And the feature of a non-reassuring variable deceleration that most significantly indicates fetal hypoxemia is loss of variability. Loss of variability. Prolonged or gradual return to baseline. Presence of repetitive overshoots. Rising baseline fetal heart rate. Development of tachycardia and persistent decelerations. So these are typical features you might find very early on in babies with IUGR. And C-section is the best thing, but intrauterine resuscitation is something you need to teach all of your staff, especially in babies with IUGR. So what's the prospect of vaginal delivery? Of growth-restricted fetuses with abnormal umbilical artery blood flow. This was a study published 5 years ago, and what they did find out is that they can be delivered vaginally, but if there was an abnormal flow, the vaginal delivery rate was lower and the C-section rate was higher. So just anticipate a C-section if the Doppler flow is abnormal. And try to revive oxytocin challenge tests because they are sort of out of mode. People don't do them anymore on a routine basis. For IUGR babies, it might be a good predictor. If the baby shows late dissolution with the oxytocin challenge test, then you might just go ahead and do a cesarean section. So these are the conclusions. When to deliver is important. Induction versus cesarean section. How to induce. Mesopostal is likely unsafe. Expect an abnormal tracing with contractions. Specifically be cautious with an abnormal Doppler and IUGR. Get the OR and the team ready before you start oxytocin. Find out if the OR is ready. If somebody else is in the OR doing a C-section, if there are 2 ORs going on and none is available, don't start the Pitocin until the team is ready. Talk to the nurses. Communicate with everybody, make sure they're aware, and get anesthesia involved. Anesthesia is crucial. Thank you.